Good afternoon, everyone. And thank you for joining us today. Welcome to our session on antimicrobial resistance in an aging world, policy challenges, and equity implications. I am Angela from HiTap, and I will be your MC for today. This meeting is organized by the Health Intervention and Technology Assessment Program Foundation, or HiTap Thailand, together with CT St. George's, University of London, and the University of Oxford. Before we begin, I would like to read some housekeeping rules. So first off, please pay attention to the fire exits, which you can see behind you. And also, we will be taking photos and videos during the session. And it will be a very interactive session. So please ask as many questions as you want. Our speakers will be ready to answer you, I hope. And also, just some advisory warning. So during the launch of GAPI in the afternoon, there will be a popping sound. So just a short warning, I hope you all won't get startled. And for our session today, we will be highlighting the unique vulnerabilities of aging populations to AMR with emphasis on health systems, policy, and equity dimensions. We will also be launching the Global Antibiotic Policy Initiative, or GAPI, as a platform for international cooperation on cost-effective AMR policy development. So we would also like to share the agenda for today. So for today, we will start with a very eye-opening keynote session, followed by a Q&A. Then we will have a panel discussion, followed by a 20-minute break. So you will have the chance to enjoy your coffee break. And after the break, we will have 2 speaker presentations and an interactive Q&A. So you have plenty of chances to ask questions, and when you do have the opportunity, please take it. And then we will close with the launch for GAPI and also a group photo at the end. So please stay tuned until the end of the day. Okay, so I know you're all excited for today's session. But before we begin, we would like to get to know you more, and we are going to be using Menti. So on the screen, you'll be able to see the QR code. Please do scan it, and please do answer the questions. And if you have any trouble accessing, please raise your hands, and our team will go around and share the QR code with you. Okay, maybe we can keep the QR code for a bit. Anyone having issues with scanning? Okay, maybe our team can share the QR code with you. Thank you. Also on screen. Okay, I see a few people logging in. Ooh, the numbers are rising. We have 27, 28. Okay, more? Okay, we have around 28. Maybe we'll wait for a few seconds, and then we can start. Okay, I hope everyone is logged in. All right, we have 30 people, so maybe we can start the Menti. Okay, so I hope you all know Nicolas Cage. I mean, I do, so I hope you know Nicolas Cage, but what level of Nicolas Cage accurately depicts your mood today? There's quite a few options, so I hope it covers all of your mood, but I hope everyone is choosing him that's a bit happier or like confused, or are you tired? I hope you're not tired. We still have a long day ahead of us. Oh, okay. Most of you number 9. Why number 9, may I ask? Oh, wow, okay. Is it because the topic is confusing, or it's just that, I don't know, you're just tired in general? Okay, all right, so I think we can go to the next question. And for those who just came, you can scan the QR code or copy the code that's on the top. Okay, next slide, please. Where are you from? Now, PMAC has a lot of international participants, so we're curious on where you're from all around the world. Oh, I see some from Asia. Oh, okay, so we've got a variety of participants. Yep, keep the numbers coming, keep the numbers coming. Okay, so I think a majority is in Asia, but we also have some from the Americas and also some from Europe. So we have quite a diverse participant today, which is nice. And of course, you'll be also have the opportunity to interact with your fellow participants at the end of the day. All right, maybe we can go to the next slide. What's your favorite Thai food? Is it mango sticky rice? I know that they had some mango sticky rice at the lunch table. Pad Thai, Tom Yum, or Som Tam? Oh, we have a lot of mango sticky rice lovers here. Oh, that's nice. I think while you're in Thailand, I hope you all have the chance to try out all these different food. Okay, so everyone's loving mango sticky rice. Yeah, me too. I love mango sticky rice. Okay. Oh, Som Tam also. Interesting. Is it not too spicy for you? Okay. No? Okay, that's good to know. All right, okay, maybe next slide, please. Okay, so this is a bit of a serious question. What is your primary area of work? It's a word cloud, so I think you can fill it in. Health policy. Oh, wow. Meetings? May I know what you mean by meetings? Okay, we have a lot of health policy people. Editor. Oh, clinician. Okay, the health policy is the biggest one. That's nice. Pharmacy. Oh, like me. Okay, HTA. Environmental health. Interesting. Governance, epidemiology. Okay, so I think we've got quite a variety of people with different backgrounds. I think that's good to know. It'll be also interesting to hear your thoughts as well on the interesting discussion that we are going to have today. Okay, maybe we can go to the next slide. Okay. In your view, okay, this is a bit of a serious one. What are the biggest challenges in tackling AMR in aging society? Okay, I'll give you some time for this one. Knowledge. Interesting. Like maybe increasing awareness. Collaboration. Anything else? Okay, we see knowledge, awareness, cost. Access to knowledge. Okay, so I think a lot of it comes from knowledge. There's also access, awareness, uncertainty. Interesting. And I think for today's session, we'll be able to hear more from our speakers as well regarding what exactly are the challenges and what ways can we collaborate to tackle this as well. Okay, maybe we can go to the next slide, please. How are you feeling? It's only recharged and ready for action, curious and keen, and caffeinated and motivated. So we don't have an option for tired or sleepy. So you are only allowed to feel curious and excited for today's session. Okay, curious and keen, caffeinated and motivated. Okay, I'm assuming that people got a lot of coffee before coming into this session. No, that's fine, it's good. Ready for action, recharge and ready. Okay, so a lot of you are curious and keen, which is good. Okay, maybe the next slide. Oh, okay. Okay. All right, so I think that's it for Menti today. Okay, so now it's, we've gone to know each other better. I've also gone to know you better. So I hope you're all freshened up. We will now start with the serious stuff. And to start off, I would like to introduce our keynote speaker. So Professor Mike Sherland is a globally recognized leader in AMR. He is a professor of pediatric infectious diseases at St. George's University of London, where he is leading the Antibiotic Policy Research Group, a WHO collaborating center for antimicrobial policy and stewardship. Professor Mike has served as a senior advisor to the WHO for many years, and he also chaired the antibiotic group of the WHO Essential Medicines list. So if you know the Access, Watch, Reserve, or maybe Aware classification system, so yeah, he was chairing that committee. So without further ado, I would like to welcome Professor Mike Sherland.
Thank you very much indeed, and thank you for inviting me to be here today. And I'm delighted to talk about this really, actually, very important and very challenging problem for the future, and then also to launch GAPI. And the team, the HitApp team, have got some interesting launch ideas. So there's going to be quite a lot of fun, and Yot and I are going to be doing all sorts of things later on. So you really want to stay and watch, because there's nothing quite like sort of seeing your more senior members of your team really making a fool of themselves. It's by far and away the best end today, I always think. Okay, can I have the first slide? Oh, I've got a little pointer. How exciting. Okay, fine. Okay, so why focus on aging? Well, this whole meeting is focusing on aging, and correctly, because obviously the global population is aging, higher infection risks, more healthcare exposure, higher antibiotic consumption, as we'll come on to, particularly a disproportionate AMR burden. And so we know that actually the population, every talk you go to has the same sort of slides and the same pictures about the sort of the increasing demographic. And certainly by 2050, at least 2/3 of the world's population aged over 60 will be living in LMICs as well. And Asia's elderly population is predicted to be approaching 1 billion by 2050. And so, and we understand, and this whole conference has been about sort of kind of the change in fertility rates, and particularly across Asia, the focus on sort of life expectancy, and every single room you go into, everybody then has the same slides as the introduction, and then they talk about their problem, and and so it's always the sort of every meeting you go to, there's the sort of an introduction, and then you get on to sort of whatever you're talking about, which is the sort of climate change, obviously a lot here, and many other components of financing elderly health services and the other components of that. My job today is to try and convince you that the nexus between sort of an aging population, demographic change, particularly in Asia, where of course is one of the highest regions for antimicrobial resistance, is in fact a particular focus and is something that's received relatively little attention so far of what's going to coming as the future. So we know approximately about the sort of current AMR burden. This is IHME data, which you have to take with a sort of, as an estimates, and obviously about sort of kind of, over 1 million deaths or so can be attributable in a broadest sense to antimicrobial resistance, and around 5 million sort of deaths have some sort of relationship to antimicrobial resistance in the causative pathway, I think is a sensible way of trying to do that. And that's comparable to other leading infection causes, and it's because it's one of now the leading cause of infectious mortality. But the point being is that if you look at the overall what's happened to when you start breaking that down by age, then you can see there's a steady decline in infant and child mortality. That's been going for a very long period of time, and actually, antimicrobial resistance reduction is is the same as all cause under 5 mortality, and actually all the mortalities under 1 mortality, and the only one that's sort of really stuck and sticking is neonatal mortality, and we'll come and have a little talk about that. And apart from that, then of course there's a whole sort of flat period of time, and then a sharp increase in the relationship of mortality, particularly age over 70. And it's very interesting that, in fact, it's 60 to 70, 70 to 80, age over 80, as we'll come back and see, is a sort of an increasing step rate of mortality there. And by 2050, IHME GBD estimates suggest that actually by 2050, more than 2/3 of deaths attributed to AMR are in this age group. So there's a disproportionate burden of antimicrobial resistance in this population, and in the very young and the very old. So like many other causes of mortality, infection mortality in particular, for reasons of sort of frailty and reasons of immunological immaturity, there's this U-shape, this strong U-shaped curve, which is quite sort of kind of basic. So, and that can be seen by this quite dramatic, when you start to have a look at the data and pull it apart a bit and look at the variation of AMR attributable deaths and take by age group, there's this steady dramatic increase that goes up in terms of the AMR attributable deaths in particular, associated with by age group. And also, this is likely to increase. At the moment, there's a sort of sharp rise projected without intervention. And in terms of global AMR at the moment, in terms of global AMR policy, we have, in truth, very little intervention. We have a number of sort of kind of policy levers, but as you saw from the recent Lancet AMR series, even if we implement everything that we think probably is effective and have reasonable data from being effective, the impact of that on sort of AMR mortality is probably about 15% or so of the total burden. So there's still a huge research gap in terms of trying to think about the different interventions and thinking about sort of what those interventions might be, and not alone implementing those interventions. So it seems likely that in the context of particularly of other global public health, it's trying to that without really focusing on future interventions, and particular focusing on interventions in older adults, then the main impact on sort of AMR burden is going to be very difficult to tackle. So, and that's in many of the IHME reports, it's in sort of a lot of the data that comes out, but it hasn't really necessarily received the attention that it sort of deserves, I think. So what are the bugs that are a major problem for a lot of the groups? Actually, in the elderly, it's pretty much the same pathogens that seems to be causing the problems in younger population, which is the gram-negatives, E. coli, Klebsiella, Staph aureus, particularly MRSA, and hospitalized patients, particularly if they get onto ICU, Acinetobacter, many of Pseudomonas, and many of the other sort of hospitalized patients. So there's nothing specific about this. It's not related to a new collection of pathogens, a new collection of bugs in the elderly. It's actually the similar bugs, but it's the rate of infection, if you like, the attack rate is where that comes the problem. And what we have to recognize is that this is complicated because it's the bug drug resistance rates are actually vary markedly between countries. This shows absolutely not at all. So that's very helpful because it means I can describe it to you and you don't know whether I'm telling it to you right or wrong because you can't see it. So I'll have a go. And this is recently data came out from an analysis from LSHTM and of the European data, and this is looking at all the microbiology data from Europe, which is EASNet data, and this is from Gwen Knight's group. And the sort of first thing you can see, or first thing you can't see, is if you look at all the bugs at the top, Acinetobacter, E. coli, and all the different pathogens, what you can see is that the males are in blue and the females are in red. And there is a more difference in the mortality rate by taking just age and sex. What is also quite interesting is that this is one of the first major analysis of the impact of sort of mortality by breaking this down by age and sex from the European microbiology data. And it's sort of kind of quite interesting. That's the first time it's been published in 2025. So if you're thinking about doing research in this area, there are lots of unanswered questions. There's many things yet to do. You might think that that might have been done before. And then And so I think that's the first step that you can see. And then also below, then you can see the sort of mortality rates and predictions associated with different age groups, and the colors aren't sort of kind of, aren't very concerned. But actually what you can see is that sort of age groups going up from the sort of kind of 45 to 55, 65, 75, 75 to 80. And so just by looking at the picture, you can see that the mortalities go up fairly sharply. As you get up to the sort of, starting up into the blues and the purples, which is in that 75 to sort of 80 age group, then the AMR mortality goes up fairly sharply. So it's really quite striking. If you're down in that sort of 35, 40, 45, 50 group, and as somebody who finds themselves rather surprisingly sort of kind of in the blue group, I found this particularly interesting to look at. And one of the other components of this, I think, and we won't go into the details of that, is that there's two separate things happening here. There's the demographic shift, so that people are moving across from that 45, 60, 65, 70, 75, 80 to age groups. And then the second is the rate within those groups, of course, of serious bacterial infections. The rate of mortality outcomes, of course, is higher and higher in each age group that you get. So you have more and more people pouring into the age group, and the mortality goes up every age group that you get. So as this whole demographic waves come across, then that mortality is going to change. The other complexity, which in this, is that even across Europe, the mortality between the sort of the bug and the drug and the sort of age group isn't the same. So it's not standard. It's not like, oh, well, all the way across Europe, actually, when you get here, you get Klebsiella. When you get there, you get Acinetobacter and there. So there is a variation by country, because countries have their own resistance patterns. Countries have their own sort of kind of patterns on their own sort of spectrum. So it then becomes quite a complicated pattern, because you're seeing a very different sort of kind of spectrum of disease even across Europe. So there's the large group, and then it comes down to the sort of interventions that you might need. Oops. So what's the sort of common causes of the infections? Obviously chronic bronchitis, chronic obstructive airways disease, sort of kind of more lower respiratory tract infections, urinary tract infections, bloodstream infections, hospital-acquired infections, and particularly the whole concept I won't get into today around long-term care facilities. Very elderly adults and neonates and babies, will also then have bloodstream infections relatively quickly, will overflow into sort of bloodstream infections, and that then becomes, and also like small babies, as a pediatrician, I'm very used to, but also in the elderly care, people are not so obviously septic, so they're not so dramatically ill, so it can get ill quickly, and nobody notices, so much, and so there's a whole sort of delayed diagnosis and delayed recognition. And immunosenescence is really complicated. Different parts of the immune system begin to sort of kind of fail, and you don't have memory, so much memory of many things. Frequently including sort of where you left the car, and also about sort of kind of whether you've met this particular bacteria before or not. And they're the same sort of thing, really. It's just that sort of slight beginning of that, and that all of those mean that your white cells and things are not fighting the infection so well, and so that all tips over what relatively starts as relatively minor infections, then become more serious infections. And and then obviously multiple comorbidities, and then frailty sort of has a complex, WHO has a sort of frailty as an intrinsic capacity, which is quite a complicated issue, and then that leads into sort of the multimorbidity as well. And clearly, obviously, older patients, invasive devices, urinary catheters, and then many polypharmacy with a lot of different medicines that can then sort of lead into all of the concerns associated with that. So, and allied to that is frequent health exposure as a problem. So I work in a very large, tertiary 1,000-bedded hospital in sort of South London, and in our hospitals, our big tertiary bedded hospitals, half of those patients who get admitted to hospital had been previously admitted to that hospital within the last 6 months. So it's the same patients coming back again and again. The first thing is, of course, the patients who get admitted to the hospital never leave because there's they obviously then get sort of stuck in hospital in terms of all the social care problems. And then when you do come out, then come back again. So there's an ongoing cycle of the same patients, exposure to healthcare infections, and then recurrent sort of kind of exposure, and then of course then acting as the transmission dynamic, and then sort of and that becomes a problem. And then of course moving across to long-term care facilities, transmission around long-term facilities, then back into hospital. So there's a real nexus of transmission dynamics within this. And a lot of then patients who have chronic obstructive problems get on prophylactic antibiotics and then drive resistant, and also surgical procedures. And then particularly if you tip over into intensive care, wide ranges of sort of a nosocomial transmission as well. So antibiotic use in the elderly is very complicated because in some senses, like babies, they have a higher rate of infection, a weaker immune system, so therefore actually need more antibiotics. And it's appropriate to treat infections. Indeed, it's better to try and treat infections early and trying to stop patients coming to hospital. So and so one has to be more careful about sort of targeted stewardship. Stewardship is trying to make sure the patient is on the right antibiotic, stopping early and elsewhere. There is a real dearth, there's a real lack of well-controlled literature in the adults to work out, should you be actually is your antibiotic at the moment? WHO has the AWARE book, which gives you guidance of 35 infections in adults and children in the primary care and the hospital setting. It covers probably nearly 95% of infections, and they're adding chapters as time goes on. So nearly all sort of treats sort of kind of guidance to do that. And it's exactly the same guidance as whether you're a perfectly healthy 20-year-old or whether you're a sort of an 80-year-old pitching up to sort of A&E. So there's no at the moment there isn't any good way of trying to sort of kind of prioritize patients who are at higher risk of more serious infections, and that's under discussion at the moment. As we talked about, higher rates of infection, less clinical concern, and genuine concern about higher risk of complication and selection resistance. So, it's not easy. It's not straightforward. It's and yet, more and more, we also know, like antimicrobial resistance, ever-increasing rates of infection, ever-increasing antibiotics is the highest risk for being colonized or being reinfected by another more resistant infections in the future. So, and the impact of that is we see, of course, all across the healthcare systems. Every meeting I've been to during this week or the last few days has been discussing sort of longer hospital stays, that the impact on healthcare costs, the problems associated with high mortality and increased hospital stay. And so there is this, problem, which is a sort of and I'm not a health economist, I'm a pediatrician. So, but of the obviously if I'm a neonatologist and when I'm doing neonatal sepsis and pediatric trials, then we have obviously a lot of DALYs associated with sort of impact on trying to treat younger children. However, the healthcare costs associated with constant readmission, length of hospital stay, and resistance is a very genuine problem that is only going to go on. So there is a sort of clearly a need for enhanced infection control, but frequently in many settings, it's really not clear about what the most sort of kind of most efficient and the most cost-effective investment is for infection control. So what you can see is we're building a picture here of a range of different things that need to be done, and this is the sort of, if you like, is a microcosm for AMR. Whenever you go to an antimicrobial resistance talk, you have the person who gives the talk on stewardship, and this is the thing we should be doing, and then infection control, but that's the thing we should do. Then we talk about vaccines, and that's the thing we should be doing, and then diagnostics, and that we should be doing. And it all depends on who's talking. If it's a diagnostic person, it's diagnostic. If it's a microbiologist, it's a microbiology person. If it's and that's exactly how AMR conferences work. And I've been to many of those meetings. Come to ESCMID, by the way. It's a very nice meeting. And then you can get anything. You can have sort of kind of people who talk about all sorts of things. You go, good Lord, I had no idea that was going to be effective. We just add it to the list of all the things that might work to try and control AMR. And the bigger the meeting, the more people there are in the rooms and the microcosm it gets. But what you never get is anybody saying, well, actually, can we think about any comparative analysis here to think about, what is the best way of using very limited resources? And the elderly are a microcosm for that in terms of how you should be sort of, you have got limited resources, but what is the best thing to do in inverted commas? So I'm not going to get into long-term care facilities today. And that's exacerbated by, the future. And we also recognize that for the elderly in particular are particularly vulnerable to heat. And then will, obviously in terms of heat stroke and other problems, but actually what is also, very clear is that also leads to infections, dehydration, urinary tract infections, sort of, respiratory infections, making chest problems worse, more components of that. So that's a third part of your nexus, if you like, for resistance, climate change and heat, and I've been to a few meetings around that as well. So our job today is not really to walk through all of the science of the different strategies to try and prevent. More to the point is there are a lot of different strategies, and all of them cost money. And so that is the issue, and you're faced with a sort of a multimodal problem where everything you do is going to cost money, and there isn't really a sort of a clear way of trying to work your way through that. And particularly for policymakers, there's it's not easy to think about how you try and prioritize which aspects of this you're going to do and what are the resistance and what are the other components of that. So just to sort of kind of, to end, and we'll end up having a discussion, I think we do need to invest in prevention. So clearly we have to do that to try and protect older adults. We need to strengthen and sort of target stewardship within the sort of particularly vulnerable things. And we need to try targeted surveillance, and we need to work through what is the research for do that and support innovation to really think about how we can understand this problem better, this multimodal problem better, and how we can try and improve the quality of antibiotic use and try and prevent infections within a population that is, within this sort of kind of area, because this is going to happen in the sense that over the next period of time, particularly within Asia, we will have a much more demographic transmission to an older population. Those patients will get multi-resistant infections. That is going to happen. Those patients will be in and out of hospital, and that will happen. Most of these infections are getting ever more difficult to treat. The new antibiotic pipeline is not going to come to the rescue. There is really going to be nothing much new coming through for decades, probably, that is going to be treating them. So what you see is what you've got. What we have now is what we're going to have then. So we have to work out how we're going to try and use what we've got better, and where we're going to place our investments. And that's what we're going to be talking about today. Thank you very much.
So thank you very much, Professor Mike, for setting up the scene for today's session, especially on the global challenges of AMR in the aging world, as well as how it is impacting the health systems, how it's severe, and why it is needed for urgent action. So we will now have a Q&A session. So I would like to introduce Dr. Sheila Maurice Lisana, who will be moderating the Q&A session. Dr. Sheila is a project associate at HITAP International Unit, where she leads projects related to AMR. So Dr. Sheila, the floor is yours.
Thank you, Angela. So I know the audience, you have like burning questions for Mike. So the floor is now open for questions. We have microphones on both sides. And kindly state your name and your organization. Okay, anyone like to start? Okay, please.
Somebody always has to start. Once you get started, it's all right. Then everybody asks, but no one ever wants to ask the first question. But if you ask the second question or the third question, it's kind of fine.
Okay, please.
Thank you so much. I'm Tavpritesh Sethi from IIIT Delhi. I'm a professor in the Department of Computational Biology and work at the intersection of health and data science. Fantastic presentation, and I particularly loved what you said in the end, that what we see is what we have. But I don't see a lot of initiatives around building data-guided stewardship that is more forward-looking, proactive, rather than reactive and looking backwards. Any thoughts on that? We do work along those lines, but I would like to listen to what your thoughts around building that is.
I could not agree more. So it's a failure, isn't it? So I mean, God knows there's enough failures in the AMR world, and that's another one we can add to it because we're just not using the data appropriately and properly. It's complicated. All of us who work in this area, and we're very engaged in sort of, thinking about optimal use data and how we can try and do that. And we'll talk a little bit more about that, and Aislinn will discuss some of that later on. And we are all aware of the fact that actually the complexities of data permissions, data ownership, data use, and then feeding those data loops back and to try and target infections. So. One of the problems that we've had, I think, is that with stewardship is what's the gold standard, and so what are we aiming for? Where one can try and say, well, this is what we're aiming for and this is what we're trying to do, but there isn't really, it hasn't been particularly a gold standard. So many, studies will do the gold standard, which is against the hospital guidelines. Yep, maybe, fine, good. Which are not always terribly strongly evidence-based and, vary from hospital to hospital and randomly decided by some random doctor who goes to, and so I meetings where they're actually all, the evidence base is a collection of doctors sitting in a room. Frankly, on the scale of evidence, you don't get a lower than a collection of doctors sitting in a room. If it's a closed room, and actually you can even run it. The more doctors you have sitting in the room, the less the evidence base. It's to scale it across 10 doctors. Really, goodness me. So I think it's working out what your gold standard is, working out better trials to try and work out what your gold standard is, working out data systems that will talk to each other so that you have a standard methodology across that, ideally interoperable data systems that will actually allow some data standards to be set across different settings so that you're not trying to collect that, and ideally working one's way towards automated data responses. What we've been trying to do is to think about then programming in, so like the Aware book goes into a program so that then, Mia's been doing that, so you actually get automatic observe as expected, the whole thing becomes automated. So I could not agree more, and it definitely needs innovation. And of course, a lot of that work has been led from India as well. I'll be happy to talk about that afterwards.
Thank you.
All right, thank you. So anyone else in the room?
Yot had his hand up.
Please. Okay.
Thank you. Just following up, but more a question about communication with AMR. There's been quite an interesting situation, I feel, in Singapore, where there's an ongoing problem of Elizabeth King drug resistant in there, but it's coming from TAPS, they've noticed. And I've only heard communication about this in, I think, one journal article, and other times it's just in conferences, and it feels very private. And we were having a patient advocacy meeting at some point, and I was representing my group, the Strategic Pneumonia Alliance. And I was asking why they're not communicating this a bit more broadly. And it was a very tense conversation between being responsible as a hospital about not wanting people to be afraid of the hospital, but then I was trying to ask why that's dangerous when, so what are your thoughts about trying to communicate these kind of strange situations?
I think it's it's poorly done and will need to be done better. Fundamentally, every hospital has an outbreak all the time. They may or may not know it, because in fact now whole genome sequencing comes through. Now there's a lot of better understanding of the transmission dynamics. They're very interesting studies looking at that transmission of plasmids, in terms of the part of the bacteria, sweep through the hospital. And in fact, you can have the same plasmid that is walking through your hospital, and it's a Proteus outbreak on your renal ward. It's a it's a Klebsiella outbreak on the on the surgical ward. There's another outbreak, and they all think they've got a different problem, but actually they've got the same plasmid. It's just walking through the ward, happily walking through the hospital. So as we move to better understanding of that, And what it runs is a waves and waves and waves, and then occasionally you get a little splosh, and oh look, we've got an outbreak. No, you didn't. You always have an outbreak, and actually it's just running all the time, and and occasionally it just kind of puts its head above the surface. It's like a seal, it's like oh, and and they'll have an outbreak. It's fine. Hit it on the head and it's gone away. It's actually gone underwater. So I think it's quite. So the comms around that for hospitals is really hard. So a hospital puts out a comms that says, we've got an outbreak of X or Y. Then at the moment, the very obvious thing to that is it gets escalated. It can get escalated very quickly, become a real problem for that hospital. Sometimes that leads to political action, wanted or helpful or not, as it might be. And then it becomes sort of and then that becomes a sort of, why would you want to put that out as a hospital? What would be the role of that? Why would you want to do that? And that, of course, has a problem for then data and has a data transparency and the other components of that. So I've have tried to help control many outbreaks in neonatal units when I've had sort of many, and so it always becomes very tense and very difficult. I think what will happen, sort of kind of sadly, is that the expectation and the reality is just going to get worse. And then as it all just gets worse, because it will all get worse, then, actually that's will come just generally more accepted, because that's what's running all the time, I think. And it will be harder and harder. Oh, 5 minutes, good Lord. Anyway, I'll stop. It's all going to get worse.
So anyone else who want to ask a question, please?
So I have a question. Sorry. So my question is about the burden of the AMR in the aging population, that you show that, of course, there's a death rates is, there's a real burden. But in terms of the carriage, we in Hong Kong we have seen quite a lot of the AMR carriage in our elderly community, especially who are living in the elderly homes. So how can we resolve this issue? And this is one of the problem that we are facing. I just want to hear from your perspective.
So that it would be helpful if we could. So it would be very nice that we could. At the moment, we don't have any way of doing that. As you know, that is very strongly evidence-based. People have been trying to do lots of components. I mean, many of the carriages just, when you start to look at the mass of the sheer bulk, the massive volume that you've got, the transmission of the gene dynamics within that. The fact that actually many of Klebsiella loves fomites, it just loves surfaces, and so patients carry Klebsiella and then put their hands everywhere, and the nurses have Klebsiella. Everybody's got Klebsiella. It's on everything, as you know. So it's a real problem. Lots of disinfectants, now becoming more resistant, and carriage. I think it's going to be really hard to get rid of carriage and alter carriage. I'm not sure that's going to be possible because of the impact on the microbiome and the way in which the microbiome have a longer conversation. And I think it's a bit like the others. What you're trying to do is to reduce every single sort of selection pressure that you can. And then try and prevent as much sort of spillover into serious infections as you can. Carriage is going to be tough.
Also, I want to introduce myself. I'm Heng Tong from the Chinese University of Hong Kong.
Yeah.
So I'm also leading the One Health AMR Center.
Yes.
So, but I don't see One Health context here in the aging AMR. So how can you put that One Health into this?
We can always put it into it. So we constantly do that. So as you'll come on, actually, GAPI has got a One Health sort of kind of component, because there is that interrelationship between sort of kind of human health and animal health, absolutely clear, particularly at that the genetic transmission and colonization. So we won't have time to go into it because I've only got about 1 minute left. But actually, I'm happy to talk about it afterwards. But there's a strong One Health agenda within this.
So we're down to our last question. Don't worry, we still have Q&As after the panel discussion, and then after the break, after some presentations, there will be another Q&A. So kindly reserve your questions. Okay, please.
Thanks for starting this interesting discussion. Ben Johnson, I'm Chief Editor of Nature Health. It's a new journal from Nature, and the Nature portfolio. And perhaps I'm a little more optimistic about new antibiotics, because there are some AI tools related to discovery of new antibiotics. But my question is around solutions, other solutions. Do you think the solutions mostly will come from how we care for older people in terms of antibiotic stewardship, or how you discharge patients, or, and maybe it's both, it's more of a whole of society approach around around communication, around antibiotics in animal feed? And if it is a whole of society approach, how can you or people working in this field influence that?
All good questions, and in 1 minute that's going to be good. So I'm immensely optimistic about new antibiotics and the development of new antibiotics. I've been immensely optimistic about that for over 40 years. So, one of the, if you're going to be working in antimicrobial resistance, you have to be immensely optimistic and almost pathologically sort of kind of positive. So your question is good, and I think it's sort of it's a lot of what I think we're trying to do here and in Gappy is to, and in other areas, is to try and work out that question, which is, what is spillover? Where is the transmission? Where is the transmission dynamics? What is sort of actually relevant to what is sector specific and what is not sector specific? And how is that vary by geographical location? How will that be different in Malawi to Singapore, for example, and those components? So I think that's one part of it. And then there's this, and that's the sort of, if you like, the bottom-up whole systems approach, which is trying to work out where do we need to focus the sort of, our breaking of that of the transmission pathways. And then the second bit is the sort of is more that that health systems component, which is fundamentally keeping everybody out of hospital, as much as possible, because that's where the transmission epicenter dynamics are. And I think there's going to be this enormous focus is going to have to be to think of every possible way to try and make sure that actually one keeps patients out of hospital, or they rapidly leave as well, because there's most of you're probably acquiring ESBLs, and others are sort of 10 to 20% per day. So you just need to get out as quickly as possible, and then we need to try and think about how we can helpfully reduce every exposure as safely as you can. And I think fundamental to that is actually better research. And better sort of targeted research in this particular area as long as others. And so I think we thank Nature for their sort of kind of their long-standing interest in this area, because they have published many of the key components of that, and I think this is a strong area for really focusing and encouraging future research in the area as well.
Thanks, Mike, for the very interesting presentation and answers to the questions from the audience. Now we'll have the panel discussion moderated by the head of HITAP International Unit, Sodomini.
Thank you again, Professor Mike. Thank you for setting the scene, and thank you, Dr. Sheila and Angela, for also getting us all revved up. Now we'll step into a second session where we'll be treated to 3 different perspectives. Someone asked about data. We are going to hear a perspective from a researcher and data scientist. We are also going to get a perspective from a practitioner from our host country, Thailand, and we'll also hear a global health perspective. So let's get started. I'd like to introduce Ms. Aislinn Cook. She's a senior research fellow at City St. George's, University of London, and her primary area of focus is about data and how we can use it to make optimal decisions in terms of antibiotic prescriptions. So with that, may I ask Aislinn to please come to the floor. Please welcome her. Thank you.
Is there a clicker? Perfect. Thank you. Hi, everyone. Good afternoon. Nice to be here. Thank you, Sodomini, for the lovely introduction. How do I start it? This one? Yes. Okay, great. So today I'll be talking not about the actual numbers that come out of these estimates, but really kind of setting the stage as to how can we estimate optimal levels of antibiotic use? I mean, for lots of different countries, and what should we account for when we're thinking about that? We know, probably anecdotally and realistically, that most antibiotic use is in the primary care setting, and a lot of it is inappropriate. But how should we actually come up with targets and think about what optimal use might actually look like? So current antibiotic use is not equitable across different countries. High-income countries tend to use more antibiotics per capita than many low-income countries. We can also see that it's not equitable by WHO region, so Europe continues to use more antibiotics per capita than other regions based on the data that we have, which we can come back to. It's not perfect. But we also know that antibiotic use is continuing to rise. It's expected to then kind of skyrocket, or we will have, as Mike kindly set the stage, the demographic transitions and more infections, maybe, hopefully not. Antibiotic use is kind of expected to keep growing. But when we think about infection deaths and the burden of infection, that's actually kind of got the inverse pattern to where we see the most antibiotics used. So you can see here that Africa has a huge number of infection deaths, Southeast Asia has a huge number of infection deaths, and really Europe does not. Europe has a much lower number, and this is also by income group. So high-income countries and upper-middle-income countries really have way lower death rate for these infections than lower middle and low-income countries, which is pretty much the opposite pattern to what we see about where the antibiotics are really being used. And then we can look at this even further by age. So Mike kind of mentioned this U-shaped curve, and it's very pronounced for certain infections. You have your neonates, so 0 to 6 days, the really small babies, and then your much older population. And those are your really vulnerable patients. But we know that also a huge amount of antibiotics are actually used by all of us in the middle here. And this is looking at the AMR burden by death. So you can see, as Mike very much already said, AMR deaths in the elderly are way higher, as well as in the neonates. So that tells us that where we've got lots of infections, it's not so evenly distributed, and it doesn't really seem to match where we see antibiotic use patterns currently. In 2024, the UNGA on AMR agreed that the AWARE system, so the WHO's Access, Watch, and Reserve classification, should kind of underpin global antibiotic surveillance. And they also agreed that 70% of global human antibiotic use should be from the access category. So access antibiotics tend to be your narrower spectrum, first-line treatment for many infections, quite effective, lower price, lower toxicity. Whereas we do see quite a lot of use of watch antibiotics, which are your broader spectrum, ones that are a bit more expensive, a bit more toxic, and also with higher selection of resistance. But that's a global target. So what does this mean for countries to try to think about what their own target should be, how do we implement a global target, and how do we actually account for these population factors? So I've been working on some research thinking about this question about how much antibiotic use is really needed for a country based on what's going on, and how can we use the data that we currently have to start to estimate that. So I think we can all agree that your country's antibiotic use should probably be based on its population's need. So things like infection burden, countries with higher infection, should definitely probably have more antibiotics available. Countries with higher antibiotic resistance burden might mean more watch and reserve antibiotics than countries that don't have as high of a resistance burden. And then there's lots of these other factors that influence actual infection burden, so wash and access to safe water and sanitation, as well as infection outcomes. So demographics is kind of a key one with that. If you've got many older people, you might want to treat more infections because you'll have potentially worse outcomes, lots more comorbidities, and other things like that. So these population factors should influence prescribing and use of antibiotics. So how can we actually start to estimate that? So we've used a benchmarking approach, and I'm not going to go into the details of it. It was quite complicated, but the paper is, I think, in the works of going up onto medRxiv, so I can have Sheila maybe send the link around later. But really accounting for these sociodemographic and infection differences and AMR incidents, you can kind of group countries into peer groups and think about using benchmarking in a peer comparison model. And so what we've done there is, using this peer comparison model, actually estimated what you'd expect total antibiotic use to be based on kind of good peers in different groups and based on the AWARE book, and then again based on infection burden, estimating AWARE antibiotic use. So how much watch antibiotics do you need? Are you a country with a lot of typhoid, with a lot of dysentery? If you're not a country with a lot of typhoid and dysentery, actually you might need less. If you have tuberculosis, how much lower respiratory tract infections do you need to treat? Obviously, there's future work to do. So right now we've estimated this at the national level, but thinking really about subnational needs will also depend on regional variation and demographic factors. And there is this piece about thinking about what projections in the future. I think to your point, this is thinking about what do we need right now or what did we need last year, but actually what will we need in the next 5 years, because that's how procurement works, that's how we think about that, and what will that look like as demographic shifts occur, infection risks change, as well as AMR. And this is really based on thinking about like risk-based need. So these are, let's see, where am I supposed to point? Oh, here we go, yeah. So this is just the kind of high-level estimates that have come out of this model. So we estimated for 186 countries. And what this allows you to do, if you estimate optimal use, is to then say, okay, you can compare it to your expected use, your current use, and see actually what the difference is. Where might you be overusing? Where might you actually be underusing? Certain countries are definitely not using enough, potentially, or might not have access to enough antibiotics. But we can really see that actually where you would expect countries is these lower income countries are expected to have much more antibiotic need than some of these higher income countries. So cluster 4 are your high income countries. Let's see. Oh, how do I go back? You're also expected to need a lot more watch and reserve antibiotics based on higher resistance, which we know is in lower income countries. You're expected to need more watch antibiotics where you have a lot more, like I said, typhoid, dysentery, more lower respiratory tract infections, and other things like TB. And then also in a lot of these high income countries, really almost all of their antibiotics should be access antibiotics. Definitely most of these countries could be meeting more than the 70% global target on their own. And what this means is that global target is actually quite appropriate, but some countries will need less than 70% of their antibiotics to be accessed because they have these higher disease burdens. And that we really need to start thinking about this in kind of absolute numbers. How much do you need for your population? So this is just kind of setting the stage of where GAPI then comes in to think about, well, okay, we might be able to estimate this, but how do we get there? What do we do? Where are we going to get the best ways to go forward? So yeah, thank you for listening, and I will pass it over to Beth.
Thank you so much, Aislinn, for providing a very rich set of readable graphs as well. So thanks for sharing that, and I'm sure it'll spur more questions and discussion later. We'll now switch gears a little bit, and we'll hear from Dr. Nithima Sumpradit. She heads the Systems Development Unit at the Medicine Regulation Division in the Food and Drug Administration of the Thai Ministry of Public Health. She is the nodal person when it comes to anything related to AMR in Thailand. So please, if you are interested, please do reach out to her as well after. And she'll be sharing some of the more practical aspects of implementing some of these interventions in the context of Thailand. So Dr. Nithima, over to you. Please welcome Dr. Nithima.
Thank you very much. Because AMR is a global issue, and countries required to maybe urge to develop their own national action plan on AMR. In the past, we focused on the One Health approach. But right now, the context has changed. Aging, equity, and gender difference are coming into account. So my topic is about whether or not we can integrate this change, like aging and equity, into the NAP AMR, and what is the challenge. I don't need to talk much about the importance and the impact of AMR on aging. So I think everybody knows that maybe in 2024, that the UNGA political declaration have a new landmark, that they have a lot of commitment, 15 pages of the commitment. And they mentioned about the importance of the AMR and at all ages, and they also acknowledge for the vulnerable population, including the elderly. And in the next, in this year, in May, we're going to have the second global action plan on AMR, which is like aligned with the UNGA political declaration. And all these global declaration or global policy, they have the focus on like whether like in terms of the availability, affordability, accessibility in one group. So I can group this intervention in one. And another one is in the hospital level, like the stewardship, like the IPC, like the surveillance. So the point is that I would like to share with you about the Thailand experience, how we address the AMR in that context. For example, in the hospital setting, we know that elderly or the aged people have a long stay in the hospital. And in the health system, sometimes each department, like the surveillance department or the IPC or the pharmacy, they don't talk to each other. They just do their work in the silo. So we introduced the framework we call the integrated AMR management in hospital, which is all departments need to work together. And Dr. Direk, I don't know that he in this room here, developed a mass program that try to capture the AMR morbidity and mortality. So we can see the change of this implementation. So, and we learned that the size of hospital and the region of Thailand, as well as the source of origin are like a different in each context. So the AMR solving problem is not easy because it's context depend. And the second aspect that we try to work in the regulatory system is to ensure that the new antibiotic will be available as soon as possible in our country. So as a Thai FDA, I'm from the Thai FDA, and I didn't work on the regulation part, but my colleague did. So I take that work to show it with you. So the kind of free process about the regulation. In the past, we have a long time before the new drug get into the market. But right now, we kind of using like the system like a abbreviate assessment, like a bridge assessment or the WHO CPR reliance pathway, try to shorten the regulations, the registration. Right now, we have like the commitment of the timeline that for example, for the new drug, right here, like maybe antibiotic, if you go to the channel of the abbreviation, you can go get the license or the registration by 90 days of the working day. So like it's a commitment from the government part as well, working with the market authorization. And the graph that show that we have also monitoring the input and the output of the application. So right now the trend is like the trend is that the output is more than the input, meaning that we solve the backlog in the past that we have a lot of backlog back then. The second approach that we use is like the collaboration with GARD-P, like with my colleagues, Sean Michel, that we kind of start working with the GARD-P, and Thailand participate as a clinical trial site among of the 5 countries for this drug, soliflodacin. And the Department of Disease Control is the lead coordinator. And right now the drug is registered at the US FDA already, just last year in December. And right now it's filed the application at the Thai FDA. According to the timeline that I said earlier, maybe in April or in May this year, we're going to have this medicine. And another approach is to ensure the affordability and accessibility. This need to work with the drug policy, the national drug policy. We know that the USC or procurement mechanism and national list of essential medicine is the key contributing factor to ensure that people can access and affordable to the medicine. In Thailand, the national list of essential medicine have antibiotics, like 55 items, and we kind of categorize it, align with the kind of the AWARE system, that we have the basic list, like a first line option, the supplementary list, like a second line, and the exclusive list is like a restrict or reserve. So I didn't go to detail whether or not it's completely matched with the AWARE, but I think it's kind of comparable and not different that much. And I would like to draw attention about the intersection between human health and animal health, because we know that AMR is like can transmit between human and animal. And right now in Thailand, the companion animal is very popular. People tend to raise more cats and dogs, and they have the cat pet shop over the place in Thailand. And there is a study showing that many companion animals, they use the human medicine a lot, like around 70%. And the study in Thailand, the top 5 of antibiotic use in a companion animal, like comoxicaf, like enfofoxacin, that is like a critically important antibiotic for human, right? But it's no choice. They don't have their own vet drug, so they use the human drug. And I go to the literature review in Turkey. They have a survey, and they kind of study about the characteristic of the pet owner. And they found that the age may be the factor that maybe like a certain age, maybe raise more pets. So that might be the association and maybe the pathway that the AMR can be transmit between this and the common share about the medicine use as well. And I think the 4th aspect is about that the new frontier that I mentioned earlier. Right now, we are acknowledging that they have like an issue of the aging society, the gender inequity or inequity in the socio-economics. So there is, I think I start seeing the trend of WHO and FAO try to take this issue into the consideration. So as the policy aspect for the national action plan, I think AMR is a cross-cutting issue. So maybe we need to explore or collaborate with another issue like the USC or the inequity or the gender difference more and more in the future. And it's a good timing because we're going to have the 3rd version of the National Action Plan in the next 2 years. So right now we can gathering information to understand the situation. And the challenge will be that we're going to the new frontier and we don't know anything that much yet. So we need to evidence that related to the local context. And the second thing is we need a strong leadership at the high level because you're going to collaborate with another group of people. If you are lucky, you can work, you have a friend and you have the good relationship, it's kind of very easy. But if not, you may need to go up to the high level and use the mechanism of the policy mechanism to collaborate to engage the wide stakeholder. And the strong leadership at the high level also important because it's related to the resource allocation. We know that every policy, they have their own limitation. if we can join force and share the resource, that might be the solution. And the last one is that, like the fine-tune interest, we need to open mind, that we maybe focus on AMR, but we need to open mind to listen to the interest of other aspects as well. So that concludes my presentation. Thank you very much.
Thank you so much, Dr. Nithima, for really giving an overview of the current situation in Thailand and the plans setting us up nicely for the next step. And before that, we would like to now invite Professor Alex Cook, who is the Vice Dean for Global Health at the Sosui Hawk School of Public Health, National University of Singapore, and is also an eminent modeler for infectious diseases in the region, who is embracing the world of AMR. And today he will share with us a bit more about what is being done regionally to combat the scourge of AMR. So Professor Alex, over to you. Please welcome him with a round of applause.
Thank you very much, Radhamini. Thank you, everyone. So I will be talking about work by my colleagues in the Advanced ID Network. I'm not part of the network, and it'll be my appreciation of the good work that they're doing. I may misrepresent them. If so, I apologize to any members of the network. I'd like to thank in particular my colleagues Liang, Nguyen, and David, because they really have taught me everything that I know, the very small amount that I know about AMR. So before I get on to talking about the Advanced ID Network, I'd like to talk about one way that we can perhaps motivate policymakers to put more emphasis into AMR, and that is by thinking about the cost of it. We often in health, we think about health impacts, because that to us is the primary thing. But for people in government, actually they need to be thinking about what are the costs of inaction as a way to motivate them to have that action. And so the UN published a few years ago an estimate that because of the cost of antimicrobial resistance, you could be having almost 30 million people a year being in extreme poverty by the year 2050. Right? And I'm going to show you one more piece of evidence for this. So if you think about TB, which is of course one form of antimicrobial resistance, you look at the cost of treating TB in India. If you're treating TB with your first-line drugs, actually it's very cheap. Okay, there's a big burden on the patient. They got to keep on going back into the clinic every day for 6 months. But actually, the financial cost of the medication is not so bad. However, if you have multi-drug resistant TB, the cost is substantially higher. And if it's extremely drug resistant TB, it's higher yet. You're looking at something like a 50 times higher cost of treating a patient who's got drug resistance if they got to extreme drug resistance TB. And so, there's this saying, a stitch in time saves 9. If you can prevent that, then you can prevent a huge amount of additional cost to the healthcare system. I'm not a policymaker, but to me that's a very powerful argument. Now, we've alluded to this history of antimicrobial resistance and the pipeline of this over time. So there was this golden age in the 40s, the 50s, and the 60s when most of the antibiotics which are being used today were developed for the first time. Right? Then we've had that pipeline really has kind of narrowed down over the last 50 years. For all of your career, you've been waiting for the pipeline to be opened, right? So I'd like to talk about one of the ways that we're trying to do that through the Advanced ID Network, which is trying to improve this pipeline. So Advanced ID, what is this? This is, I have been told by my colleague David, who's the co-director of it, that it is the world's largest active infectious disease clinical trials network currently ongoing. Obviously, there were a lot developed during the COVID pandemic to try to deal with that pandemic. However, this is ongoing and has over 100 sites, mostly in Asia. But if you look through all the countries which are represented, these represent the majority of the world's population. The biggest and most important countries are part of it. US not, but all the other important ones are. So it is headquartered through the School of Public Health at the National University of Singapore, so we're coordinating the network, but really it is the network itself. It belongs to the members, and I'll talk about what the network is doing to try to combat AMR. So it's got multiple different layers to this. One is trying to actually get a better understanding of the disease burden, because we often don't know, and in particular in Asia, we don't know a lot about what the burden of disease in different hospitals in different countries might be. A second is trying to strengthen diagnostics so that we can quicker get the right antibiotic to the right patients if you're able to identify what the resistance profile of the bacteria would be. We are trying to promote across the network better infection control prevention and stewardship. We are trying to optimize treatment because often doctors don't know what they should be treating the patients with next. And throughout this, we're trying to boost overall research capabilities, in particular here in Asia. So I'll talk about a few aspects of these. First, I'll talk about the ACORN HAI study, which is very rapidly recruited a large number of patients with severe bacterial infections in hospitals. I will not have time to talk about some of the other things, but we're doing some quite cool clinical trials to identify bugs quicker and to try to work out combinations of treatments quicker that will be effective. We're also looking at how we can, across the network, improve antimicrobial stewardship. But let's start by talking about ACORN HAI. So this study is basically a clinical epidemiological study. Because it brings together hospitals from around about 20 countries in Asia, it has been possible to recruit really quickly. Over a 2-year period, 10,000 patients, more or less, have been recruited. It's a mix of ventilator-associated pneumonia, about 30%, and 70% bloodstream infections. And so I'll show you a little bit of some of the results from that so we get a sense about what the disease burden would be. And I'll do it through maps because I like maps. I think they're cool. So let's take a look at these maps. On the left-hand side, we have ventilator-associated pneumonias. On the right-hand side, we have hospital-acquired bloodstream infections. Then we're looking at 2 bugs. And I'm really bad at saying the bug names, so hopefully I say them right. Enterobacterales and Acinetobacter. Okay. So amongst your Enterobacterales, which proportion of them are CRE, they're resistant to carbapenems? Okay, and you can see that on the bottom charts. And so the colors vary substantially. The first thing I want to show is that the colors vary substantially, right? They're very different from one country to the next. And as you see when you compare the different bugs, they're very different from one bug to the next. Now, I have missed off the percentages, so I'll just show you what the percentages are. They vary from 0% to 100%. It's really quite insane, the amount of resistance that we see in some of these settings. Okay, so this study, I think, is showing some major things. It shows that carbapenem-resistant gram-negatives are really a major cause of mortality. 40% of our patients died that we recruited in the 1 month that we were following them up. And of course, this clearly has a big impact in quality of life across Asia. It also shows that we need to urgently improve the diagnostics, that we can quickly identify whether this patient has got a resistant organism or not. So if they do have one, we'll get them off the first line and onto second line treatment. So what we're currently working on then is a few clinical trials. I think I've got them on the subsequent slide. Trial of rapid diagnostics versus standard of care so that we can rapidly identify what treatment we should be giving them. A phase 4 open label multinational individually randomized trial, which has been very complex for them to run in order to identify for patients what actually is the most effective bacteria antibiotic for the bacteria they've got, and to try a phase 2 trial of a novel antibiotic, which is being rolled out now. Because the network is so large, we've been able to very quickly recruit participants into these trials. So several thousand participants have been recruited over the last couple of years. And when I asked my colleagues how many of those were from Singapore, only 20. And it shows partly the advantage of being able to work across borders. You're able to recruit participants just so much faster. And these have been funded thanks to various amounts of funding from elsewhere. Okay. So I think that this is an example of the strength of regional cooperation. As I mentioned, if Singapore were to try and do all this work alone, we would have no success. Can't do a trial on 20 patients, right? But by working across countries, all of the countries benefit from this. So the Advanced ID Network has been really active also in promoting best practice. I think they do weekly seminars, and they're very open to new members joining into the network and to having ideas come through from the members of it themselves. Okay. So my time, I've been indicated, is up, so I'll stop talking there. Thank you very much.
Please hold on to it. So thank you so much, Professor Alex. Please hold on to your mic and please join the panel. And may I request Dr. Nitima and Aislinn as well to please come up for an open discussion. We hope there's been a lot of food for thought from the three speakers. So we'd like to now invite you to hopefully not grill them, but please share your perspective and pick their brains a little bit more as well. For those of you who can, please come to the mics at the two ends. For others, if you want in the middle, please raise your hand and I'll come to you with a microphone. So sir, please, over to you.
Thank you again. Tav Pritesh from IIIT Delhi. Thoroughly enjoyed your presentations, Aislinn and Professor Alex. So, and also the maps that you showed. One piece that I find lacking in all these works is the trajectories of where we are going. I think these are good snapshots, and I'll also like to bring in some of what we've been doing in India. We basically looked at more than 60 countries' data across the globe and look at how the trajectories evolve. And UK, for example, without naming many countries, do have problems with drug-bug combinations, which you would traditionally miss with snapshots. So are you looking at, so my question to you, Alex, is, are you looking at also modeling and seeing how you can actually connect with the policymakers? And a corresponding question to you, Aislinn, is, are you looking at your insights and connecting with the clinical stewardship programs? And because that's the toughest part. Even in our work, we have poster A234 coming up. It's called AMR Orbit and AMR Sense, supported by the Trinity Challenge. But the toughest challenge is to actually take data insights to the policymaker or the implementers and make it happen. How do you solve that problem?
Alex, would you like to go first?
I'll go first. Okay. So in modeling, we are looking at modeling AMR, but in a slightly different way. So the challenge that we've got within Singapore is actually not being able to correctly identify what proportion of antimicrobial resistance that we're getting is due to what different source. So how much of it is due to One Health sources, for example, versus inappropriate use of antibiotics versus transmission from others who've had inappropriate use. And so the efforts that we'll be putting in over the next few years is trying to quantify that. It's not directly answering policy questions, but I'm hoping that indirectly it will do in the longer term because it'll give us a better evidence base to inform that. Yeah. Thank you. Yeah.
Yeah, a great point. Obviously, we have to think about what this is going to look like in the future, and also how do you take those numbers and do something with them. So I think a couple of things in terms of the overall quantity of antibiotics. Most of that is in primary care. Most of that is in the outpatient setting. Obviously, most of the mortality and morbidity occurs in the hospital setting, but there's actually quite a lot we can start to think about in the primary care setting, at least from an overuse of antibiotics or improving use. So as Mike mentioned, the AWARE book provides kind of risk-based guidance, particularly in primary care. And so thinking about how do we adapt that into clinical decision support tools. We have an ongoing trial right now in a couple of countries looking at actually doing that for respiratory tract infections. And again, then trying to think about how do you take these numbers and actually talk to policymakers. And I think that's where GAPI, which David will talk a bit about later, starts to come in, which is, well, what are your interventions? How much does it cost to get to these numbers? And what kind of political will can you actually also put behind it? Because that's quite tricky. I mean, we can say you need to drop by 20 DIDs, which is a huge number, but how do you actually do that? And it's going to come from a lot of different places. It's going to be clinical practitioners, but it's also going to be at the patient level. And, what are people also using human antibiotics for? Pets, plants, and other things like that. And a lot of that you'll need good data to actually start to tease that apart as well to figure out where your best interventions can be. Thanks.
Can I ask a follow-up question?
Yes. Anyone, may I just check quickly? Anyone else? All right, please go ahead.
Very quickly, since you mentioned outcomes, we still don't have a code for a death that can be ascribed to AMR in our EHRs, I think, and we miss a lot of these deaths that happen due to AMR. So outcomes is a good way of looking at things, but I think we also need to think about how do we actually ascribe the cause of death as an antibiotic-resistant infection.
Yeah, agreed. Yeah.
May I maybe ask Dr. Nitima if you'd like to reflect on the question around data structures and also around One Health, which you pointed out to, and what that means for having a robust data system?
I think at the from the policy perspective, we may need to develop the evidence step by step. In Thailand, we don't have the good database. Everything kind of fragmented. So what we can do is that we can start building the database while we using the data as well. So it's like when the best available data that we have right now, it should be use it and don't ignore it. And the second thing is about the level of data, because at the national level we also need data. But at the hospital level, they also need data because it's a quick fix for the MR at the hospital level. At the national level, we need the data for the planning or for the resource allocation. So it's kind of, I think it's dynamic in terms of the data usage and the data structure. Thank you.
Thank you. And I think all of us in this room have some degree of role to play in using the data so that it becomes better in a way. You would like to add?
I was just going to add to that. You make a very good point that the data does exist. I mean, pharma companies know what they're procuring. Hospitals have to procure and sell and farm. So it's thinking about how can we harness some of this routine data that maybe is also a bit proprietary and people don't want to share it. But how can we work with industries and with that too to not have to set up separate surveillance systems, because that fundamentally is complicated and hard.
Yeah. Thank you, Aislinn. Anything, Alex? We'll have time for one more question. So anyone would like to ask please.
So Heng Chun from Chinese University of Hong Kong. So I'm very impressed with the work done by the first, panel member. So, but the information that we have is a little bit kind of confusing. So you're saying that even you use more antibiotics, that is not related to you are getting more AMR, which is quite, repeating that I had, in many meetings, even like last year in the Tokyo AMR meeting. So the Thailand reported that, they have been very successful in the reducing their AMU there, but in human sector. But the AMR trend is going increasing. So which is confusing that whether, how can we further enhance our stewardship program? Because people were questioning out that even we are reducing the use of AMR, AMR is not solvable. So your data also seem in that way. So can you help me kind of how I should be, talking to the policymaker and also even the public in a more easier to understand this confusion and dilemma? Thank you.
So I am not a clinician, but I think one of the key things is that stewardship is about treating the patient with the right drug at the right time. And so fundamentally, if AMR is part of that, you need to know when they have a resistant bug, but it doesn't. I think with the estimates that I kind of showed, it's not saying that, okay, we need to reduce some of them. Obviously, bug-drug combinations are tricky, knowing exactly which drugs are driving resistance, plasmids are a problem, that kind of thing. But if it can be used to actually help treat patients better and help make sure that the patients have access to the drugs that they need, so we know that there's countries that don't have enough reserve antibiotics, and how can we start to use this to make sure that you have enough of the right drugs and where you need more of them. I think that's kind of where I come from this. That's the message that I would take away. I think AMR has existed for as long as we've had antibiotics. It is obviously getting worse, but a lot of the data we need right now is to make sure that patients are treated and you can reduce mortality. The big thing is preventing deaths, preventing morbidity with this problem that we have of AMR. I think how directly antibiotic use is going to reduce AMR or slow the trajectory is very complicated. I think we hope to address some of those questions with GAPI, but it is really complicated. And so kind of thinking about your primary outcomes of patients and their health and making sure that they have access in to affordable drugs too.
I have a kind of follow-up question.
May I,
okay.
Because we are going to be having a break very soon, so I'd like to maybe, if it's okay, turn to Alex, and please do reach out to the panel during the break. Anything you'd like to add? And because this will be the last round, I'd like you to maybe reflect a bit on the title, on equity implications. We have heard a little bit from you in terms of data access and also in terms of access across countries. May I ask each of you to very briefly give some reflections, and then we will go into a quick break. Alex?
Ladies first.
We'll start with you for this particular panel.
I need more time to think.
Equity.
So in terms of the equity, I think it's a very big issue in terms of there are different types of equity. The income inequity, or the healthcare access inequity, or what kind of equity. So we need to identify it first. And then it's a new area. It's like equity is a huge area, and AMR is huge area. And when you put these two things together, it's very high complex, you can see that. And for the AMR, we also have the One Health, animal, plants. Also, as I mentioned, animals don't have access to their own medicine yet. Is that the equity for the animal health? So that is just raise a question. Thank you.
That's a good way to go into the next part. But very quickly, Alex and Aislinn, equity implications.
I think she said most of it really, that it is complicated, and what do we mean by equity? There's gender equity. It's some of the numbers that Mike presented at the beginning, where women are more affected by certain types of infections, men by others, and further, income and access to healthcare. What does that mean? We know that courses of meropenem will bankrupt families and cause bad outcomes. So that, yeah, as you say, we need to kind of start to quantify it, but it's really gets complicated.
Thank you.
So very similar. I showed the data at the beginning about cost, and I mean it impacts on those poorest members of society more than the richer members. So that we should be addressing it in order to reduce inequity.
Very nicely summarized for all three of you, and thank you. Please give them a round of applause.
Hello, everyone. Welcome back. I hope you all had a great break and feeling refreshed, because we still have more exciting sessions to come. But before we start, we want to have another mentee session. So reflecting back on our previous session. So could we please have the mentee slide, please? Okay, so I think if you have scanned before, it should show up if you still have the mentee. But if you don't, please do scan. And if you have issues, please raise your hand and our team will support. Okay, maybe go. Okay. All right, so just a quick question. Do you finish your antibiotic course? So do you finish it to the very last pill? Or are you guilty of stopping early? I hope there's no one. Oh, there is one, okay. Only until feeling better, or I'm the one giving the advice. Oh, okay. Okay, so a majority of people take your antibiotics until the very last pill, which is good. Good point, Dr. Yot. Yes. But I think we still have a few people who are still stopping early. So before the actual recommended number of pills, you have stopped, or until you feel better. Or if you are the one giving the advice, so I'm assuming you may be a health professional. Okay, so next slide, please. Okay, how would you describe the current policy priority given to AMR in your setting? So is it under prioritized, which means it needs more attention, appropriately prioritize, but financial constraints, or it's over prioritized, so relative to other health issues? Okay, so I think we have quite a few for under prioritized, so it needs more attention, and also it's prioritized, but you have some financial constraints. So I think a lot of people here are facing like similar issues. So hopefully through this session, we'll be able to see how we can actually tackle this. Next slide. Okay, and that is it for our mentee session. Okay, so I hope you are all refreshed. I hope you are much awake after a few cups of coffee or tea, perhaps. But for this next session, we are going to hear two presentations from our distinguished speakers. But before we welcome our speaker on stage, I would like first to introduce his background. So this speaker is a tenured researcher in public health at INSERM, or France's National Institute for Health and Medical Research, and is currently based in the Department of Global Health at the Pasteur Institute. And he holds a PhD in public health and biostatics from the University Paris-Saclay and was previously a senior researcher at the University of Oxford. So I would now like to welcome Dr. David Smith. Dr. David, the floor is yours.
Thank you, Angela, for that very nice introduction. Thank you, everyone, for the organization today and for giving us an opportunity to talk about this very important problem and to introduce the GAPI project. So what is GAPI? We've been hearing about GAPI throughout this session as something that we're working on, a sort of future research direction in this area of antibiotic resistance, antibiotic use, antibiotic research. And so now over the next 20 minutes or so, I'll give a presentation of the origins of this project and the kind of questions that we're hoping to answer. So GAPI, to start, stands for the Global Antibiotic Policy Initiative. So the goal here is to help create the tools to inform policy at a global level regarding antibiotic use and in turn optimizing antibiotic resistance. Our funder is the Wellcome Trust, so thank you to Wellcome for making this work possible. So a bit of context, which has already been very nicely covered by previous speakers today, so I'll just go over this briefly. We know that global efforts to tackle AMR have had limited success, and that AMR is an ever-evolving beast, and the challenges that we face in AMR change year over year, different bugs, different global health contexts. We know that reducing antibiotic use globally is essential. We've been hearing about the large amounts of inappropriate use, in particular in the primary care sector. But antibiotic use supply chains are extremely complex. We still have a hard time even counting up total antibiotic use globally, let alone addressing that overuse. Nonetheless, at the United Nations high-level meeting on AMR, member states ratified some targets to move us forward in the policy space, including the 70% access target that Mike introduced earlier. And there's a sort of move currently in the policy space towards country-level reports that report on what is the current level of antibiotic use and what are the costs and benefits of inaction. So if we don't do anything about this problem and about antibiotic overuse, what will this mean for continued growth in AMR and associated health and economic burden? And then what, in turn, are the costs and benefits of antibiotic policy interventions? So if we start to thinking about putting new interventions in place or combinations of interventions in place, what do we stand to benefit and what will it cost us? So these are some of the key questions that are driving GAPI that we hope to contribute answers towards. These include what are optimal levels of antibiotic use in different settings, in different countries. We saw a very nice presentation from Aislinn earlier, starting to get at this question. And in turn, which interventions, and in particular, which combinations of interventions are best placed to help us reach these optimal levels of AMU? What are the expected impacts of these interventions, not only on AMR burden today, but potentially on future levels, thinking about taking time trends into account, looking forward. And then, of course, are these interventions worthwhile? How cost-effective are they? Do we get good bang for buck, given our very limited global health research finances and budgets? And given uncertainty and data limitations, should governments, should global health funders think not only about intervention, but addressing more in fundamental research to better understand the clinical epidemiology, the burden of AMR, to then perhaps be smarter about the way we put interventions in place? So the vision of GAPI is that it's a project proposing the development of health economic modeling frameworks to inform ABU policy goals, antibiotic use policy goals. And the overall aim is to come up with the tools that can be used in cost-effectiveness evaluation to start to get towards the cost-effectiveness of these different combinations of interventions, with a large asterisk being given the available data. GAPI is not a project which can produce new or better data. We know we have limitations in the quality and availability of data in this space, but given the data we have available, how can we harness it best to answer some of these questions? And so the overall goal here is about this methodological framework, but we'll be starting with the UK and Thailand as our exemplar countries in which to develop and trial GAPI before thinking more broadly in future phases. So here's a quick overview of the structure of GAPI. So GAPI it has 4 main work streams, and the first 3 are all about data gathering, model development, and informing the parameters that will go into those models. So we have a first work stream about antibiotic use, understanding from baseline, where are we at today, what are the current trends of antibiotic use. And here we take a One Health lens, thinking not only of human exposure to antibiotics, but also in the agricultural veterinary sectors and in plants. In our next work stream, we think about what kind of model structures we really need. Here we're thinking about a mix of epidemiological models and transmission dynamic models that really take into account the spread of AMR through populations. And then we're also thinking about economic models and things like decision trees and Markov models and how we can integrate these together to create the sort of feedback loops that we need when accounting for the impacts of changing antibiotic use on health and economic outcomes. So the models from workstream 2 are potentially quite complex, and then so the third workstream is about the data analysis and parameter harnessing needed in order to be able to run our simulation models and conduct our eventual analyses, and those come in workstream 4, where we put our first 3 workstreams together to conduct model-based cost-effectiveness analysis. So I'll go through these in a little bit more detail, including an overview of our ongoing activities and the partners in the project who are currently working hard on these various components. So our first work stream, as mentioned, is all about global and national levels of total antibiotic use. So we've had a large phase of data collection, curation, and synthesis of antibiotic use data from different channels. Here we're thinking about the full supply chain from manufacturing down through to trade and wholesale, down to the level of prescribing and dispensing, and bringing these estimates together in different settings, primary care, secondary care, in different geographies, to get to overall levels of antibiotic use, stratified, of course, by class, by aware group, and demographic group. And some of the ongoing activities here include a first global synthesis and evaluation of publicly available antibiotic use data sets, as well as 1 or 2 not publicly available, such as IQVIA Midas. And Dr. Jha, who's a research fellow here with us today, is working hard on this evaluation, because similar to this question of age and sex spread in antibiotic use data, and surprisingly, it's only quite recently that these publicly available data have been thoroughly analyzed under that lens. Similarly, although there are many different publicly available data sets, things like GLASS, things like Animuse on the animal side, there's been relatively little effort to sort of put these together and calibrate and see how differences and consistencies relate to one another across these data sets. A second activity is being led by Dr. Angelica Nand at Oxford, which is about taking these diverse data sets and conducting Bayesian analysis and multi-parameter evidence synthesis to come to more robust estimates in our different settings and our different contexts of current levels of antibiotic use. Our next work stream is all about the development of our model structures. So we know that AMR is a complex problem, as has come up in many of the talks today. We know we have to think about transmission, we have to think about safety of antibiotic exposure, we have to think about health outcomes. And putting this all into one model is quite complex, and so here we have a whole work stream dedicated towards first thinking about the major infections that we're interested in, where in particular there's potential to reduce unnecessary overuse of antibiotics. Then bringing these together to develop the models that account for all of the main consequences of antibiotic use decisions. So this includes transmission, this includes economic costs, impact on quality of life, side effect, safety, toxicity, and so on. And then we bring all of these together to make our final model structures. And so here we have some ongoing activities as well. We have 2 PhD students at Oxford, Natasha and Madison, who are conducting different systematic reviews of transmission dynamic models for AMR. Natasha, in particular, is focusing on the relationship between human antibiotic exposure and selection for resistance in humans, and what that can mean for onward spread, at the population level. And Madison, in particular, is focused on vaccination and how vaccines can potentially be a tool either through directly targeting bacterial infection or targeting viral infection, and therefore reducing inappropriate antibiotic use. And then Dr. Sheila and her team have been very helpful and involved in these reviews as well. And then on the health economic side, we have ongoing work of the development of different decision trees for our long list of infections that we're thinking about in GAPI. Dr. Mio here with us today and Dr. Kassim Alel are working hard on coming up with complicated decision trees that account for all of the possible treatment decisions in primary care and secondary care and the interactions between them, including potential admission to hospital after an inappropriate initial antibiotic treatment decision in outpatient care, and so on. So these are our model structures, and in order to run simulation and analysis with these, we need to, of course, have the data to inform these structures. And this is here a large package of work regarding diving into the literature and understanding what are different estimates of the effectiveness of antibiotics relative to a no antibiotic care strategy. So what actual burden are we preventing by treating our patients? What are the impacts of antibiotic exposure on antibiotic resistance at the patient level, safety, toxicity, and side effects, as well, of course, cost and affordability of different antibiotic treatments in different settings. And so this will give us quite broad parameter sets in order to plug these into our models. Here we have a first major piece of work currently ongoing at HITAP, led by Dr. Sheila and her team, investigating the incidence of infection and associated antibiotic use in Thailand, using in particular, in a first instance, the NHSO data. And here we have some preliminary data based on diagnostic code of the different major infections occurring in Thai hospitals across age groups. And then similarly, we have some ongoing work out of Oxford, umbrella reviews and network meta-analyses of antibiotic efficacy. And here thinking in particular about antibiotic choice and antibiotic duration. So going into our models is not only this idea of is treatment appropriate, yes or no, but are we potentially prescribing antibiotics for too long? Can we potentially switch to different antibiotics to reduce unnecessary side effects, additional selection for resistance, and so on? And so this is part of a body of work that will help to feed into our models, which can then all come together for our main final package, which is estimating which interventions targeting optimized antibiotic use are most cost-effective. And Mike put up a list of interventions before that we're thinking about, so we're thinking quite broadly. We have vaccination, we have diagnostics, we have antibiotic stewardship and policy interventions, and we have IPC in particular in the hospital setting. And thinking about ranking these, running these simultaneously in analysis to understand in particular contexts in the UK and in Thailand, which appear to be the most cost-effective interventions to address AMR burden. And so first we have a quite complicated integration step where we bring together all of the components presented so far. So this involves taking into account our antibiotic use. I see we can't really see these pictures too clearly, but it's mostly conceptual at this point. So bringing together our baseline levels of antibiotic use, crossing these with our infection data and our carriage of resistant bacteria in our particular settings, bridging these into our decision analytic health economic models to start to map our outcomes to what we see reported in routine surveillance data, and to bring it back to our antibiotic use, to creating a functioning simulation loop, allowing us to propagate this forward and address the potential impacts of intervention. Of course, to feed into any HTA or useful health economic evidence, we need important collaboration with stakeholders, and we need elaboration of realistic strategies in different settings for really what are the best and most useful approaches for AMR intervention. And here across our project partners, including, of course, HITAP, Oxford, and City St. George's, but also the Center for Global Development and the One Health Trust, we're working on coming up with the most policy-relevant strategies. We've had a stakeholder consultation meeting here in Bangkok with HITAP earlier in the year to help inform this work. And so GAPI is ongoing. We're a little over 1 year in, and we've got a year and a half to go approximately. And so our perspectives and horizons for where this work will take us look like this. So as presented, GAPI is set to deliver a model-based framework for evaluating cost-effectiveness of AMR interventions. And the idea is that it can ultimately be adaptable, modular, used by different bodies in different HTA contexts around the world. We'll consider as well a value of information framework in this final integration piece to understand if uncertainty in our model simulations is too high, perhaps some of our parameters for certain settings are very uncertain. Our modeling can help to inform that potentially the best use of available funds is to conduct an epidemiological study or a research study to reduce that uncertainty, and that might be a wiser allocation of funds than potentially unwise investment in an intervention when we can't confidently estimate what its effects might be. As well, there will be an important piece with Anthony here about integrating microeconomic and macroeconomic modeling, macroeconomic concepts being something that are often missing from currently available cost-effectiveness evaluation for AMR interventions. And then finally, we hope that these models can be adapted and used by different agencies and stakeholders across global contexts. So thank you very much for listening, and a big thank you to our team and partner institutions.
Thank you very much, Dr. David, for introducing GAPI and its project, its work streams, and future impact forward. Maybe you can take a seat first. Okay, so next we are going to have another session from one of our speakers. I would like to welcome Professor Mike Sherland again on stage, who will share a little bit more on GAPI's roadmap for stakeholder engagement research policy dialogue. And Prof. Mike is currently leading. Okay.
Once is enough.
Go ahead.
Okay. So you're not supposed to get me. So unfortunately, this was. Oh, okay. How splendid. This is talk was being given by Professor Kuhn-Bowles, who is the co-PI and the person who's a professor of statistics and health economics at Oxford, and who is in fact the intellectual powerhouse of GAPI, whereas I'm the sort of kind of the face of of trying to put all this in the mush of AMR and trying to see if we can put this into some sort of kind of context that makes it into a usable context as well. So Kuhn sends his apologies, and you get me instead. So, and I'll go through this at speed because you've had your tea and you've already had quite a lot. So we'll see if we can sort of kind of work your way through this quite fast. And as you've noticed, GAPI is what might be called ambitious. Some people might call it over-ambitious, but it's what needs to be done because we have at the moment multiple interventions that can be taken forward, and how you can prioritize those is not clear at all as a policymaker. Of course, if you give policymakers the option of not providing with really clear and very precise advice of what should be done, with a robust evidence-based, with a really clear prioritization exercise, then the simple way of default to that is that you won't do anything. So I think it's the science failure for us not to try and produce this sort of level of prioritization. So we have major data gaps around, and we recognize those major data gaps. The data gaps around the burden of disease, data gaps on the antimicrobial use, and usable data with antimicrobial resistance. We have a lot of aggregate microbiology data, but we have to sort of think about how to use that better. High uncertainty around that, and many competing investment choices about that. And so these outputs have got to focus on real policy policy questions, and you have to provide sort of reflect decision constraints and financial constraints locally. They need to be locally relevant, but actually in a way and a methodology. And the reason why GAPI was designed this way, it has to be something that policymakers are used to seeing. So and how can you have a common language that actually IPC and stewardship and vaccines and diagnostics and new antibodies can all be discussed with a policymaker in a common sort of kind of language that is not Esperanto. So GAPI produces sort of kind of, ideally will produce integrated, cost-effective and HTA-ready models, but I think particularly this concept of explicit handling of uncertainty and the whole concept of value of information, which is all around the concept of what do we know that's pretty robust and probably could be implemented now, and what you need to do more on to try and to do that. And so, engagement through networks, through meetings, through discussions are the sort of is what we're trying to do and make sure that aligns with the policy processes. So it's, we have the idea of this is that you take a couple of countries and you do sort of deep dives and try and do a sort of exemplars, but actually one in the UK, one in Thailand is hopelessly insufficient, and that's therefore got to be moved on to other countries in the sort of in rapidly to do that. So we're very interested in sort of thinking about other partners, other countries, when we can start to try and to apply these models and to think through that, recognizing that the data is always going to be difficult. Permissions are really complicated. Data cannot leave country. Data, these models are something that actually can be done and designed in country and done by sort of kind of national agencies and national countries. There's no question here of any data ever leaving countries. Everything has to be done in country by the sort of with all the relevant permissions and everything that needs to be done at a national level. And that's all, and that's why we're working through HITAP with the concept of doing this through ATA Asia Link and the other networks that one might be able to try and do that. And so this is why it's all about a generalizable framework. He's also clear to say that as yet, we do not know we can do this. It's always good to launch a project without being sure that you actually know, probably it's okay. But you don't really know that actually until the sort of kind of this starts to run at the end, and actually the whole thing runs. Dave produces lovely sort of kind of to do that, but actually no pressure at all in producing that under any circumstances. So, and that's the sort of, and that's why, though we looked around and thought about a common language, what would be the common language? In the end, it came down to an HTA decision because countries are used to trying to think through that. Obviously, many countries have been making HTA decisions around new antibiotics anyway, as we've been discussing earlier on in Thailand and elsewhere. So therefore, it makes obvious sense to try and see if you can do that, and then producing sort of standardized outputs around that. And and then the more countries that one can work with, the more you can start to test those sort of frameworks. You can see whether they're actually usable or has any utility at all outside outside exemplar countries. But the principle is to try and see whether or not and that's using data which has very limited. Countries have remarkably limited data. If you think about glass, for example, some countries will actually just do one channel, which will be import data. Other countries have multiple channels. But at the moment, glass AMU, of course, has only one channel and then selects that. And countries often have multiple other data, as was being discussed earlier on. So, and I think I won't hammer the point about the sort of kind of the value of information, but I think that is a key part of this because it also tries to support local research agendas. So what would be useful? What if you were going to try and invest a little bit of money, what would be useful in terms of trying to do that? And you can see where we're trying to do and get to the point with trying to put the data synthesis together as well. So I think here what we're trying to do is to think about defining a more formalized roadmap. We'll be discussing a lot more of this tomorrow with the whole of the HITAP team, sort of kind of co-develop these modeling assumptions and then sort of think through webinars and developments of sort of kind of short courses of this sort of type of framework with Oxford and with HITAP, and have sort of kind of regular process by which we can slowly run this out sort of over that period of time. So, what we're thinking about now is really about the sort of kind of, trying to make the framework usable, sort of kind of calc and the KHTA networks. I'm not expecting you to answer all these, by the way. So just in case, and then thinking through where GAPI, and that was, this slide is written by Kun to talk about, well, actually, the next project, which is good, because, what we now need to do, if that works, and over a period of time, is think about how one can run that in multiple problems to maximize the global value. We'll stop with that because we're moving on to the next bit. Is it the fireworks yet? Is it time for the fireworks yet?
Not yet, not yet.
After this. Okay, don't go.
Okay.
Thank you very much, Professor Mike, for that session. Now we will have an interactive Q&A session, which will be led and moderated by Dr. Yot Tirawatananon and Ms. Titi Panchaya Panya. So over to you both.
Thank you. After you know about the GAPI, now it's time to engage.
Yes.
You are the first group of stakeholders to be engaged today.
Yeah, and we'll be here doing an open discussions on the GAPI project and also on the roadmaps, and we want to hear your opinions and also suggestions on any points we will be discussing after.
Yeah, as you learned from David and from Mike, that even GAPI at the moment we are focused on Thai and UK, but our vision is that to make use in other countries, in other settings. So today I saw, sorry to put Professor Jojo on the spot. We have a chair of the HTA committee council in the Philippines who are doing a very important job in making a decisions about whether or not that the field health to fund medicines, vaccines, and medical device in the Philippines. So I think I want to learn from maybe Professor Jojo first. After listening to the introduction of the GAPI, are there anything that you think that GAPI should try to do in order to make it useful to the HTA in the Philippines? And also from the slide, are there any support if needed to make it more confident using the GAPI product in the future? Thank you.
Well, first of all, thank you very much for the insights about GAPI. This is the first time I'm hearing about the initiative. My thoughts are, well, first, I don't know enough of what goes into the modeling to really say whether this is going to be useful. In the Philippine setting, we do health technology assessments when a technology is nominated. And that's usually nominated if there is a gap needed to fund a public health program or a benefit package of our local health insurance. So it's really to address, in a way, inequity, because after the FDA approves a particular technology, it becomes available to everyone. But if it's expensive, it's not really available to the poor. And if it's nominated, that means the government is willing to invest in that technology so that it will be available to the poor. But we are not the agency that nominates. I mean, we would like to do the assessment, but it's the Department of Health and the PhilHealth, our health insurance, our national health insurance, who will do the nomination. So it will definitely be useful to us if in case this is identified by the country as an initiative that will benefit a lot. So we look forward to your developing the models, because if there's a model, we understand it's going to be much easier for us to do our health technology assessment. So that's where I'm coming from. But another reflection I have is that when we assess technologies, we have a very specific research question that identifies the patient, the exposure, the intervention, or in this case, the technology, the comparator, and the outcome. And it seems that in your model, everything needs to be looked into. Because the model, I guess, incorporates policy versus new antibiotics versus new diagnostics, but that's not necessarily how we operate. So again, I don't know enough of what's going to come out from the model to really reflect on whether it's going to be useful to us. But in my opinion, any model, especially if it's already tested and tested by HTA, AsiaLink, and HITAP, will be useful to us. So that's all I can say at the moment until maybe I can understand what goes into the model more.
Thank you. That is very helpful. Any other reflections from the floor? I don't know, any people from any HTA agency, or even not HTA agency, you are clinician who work with maybe decision-making body in your own countries, you can also share your view. Do you want? Please.
So I do not work with HTA, and in fact, pardon my ignorance. So what I would like to ask and understand better is these models can be used for policy at maybe at an aggregate level, maybe a unit, a hospital. Are we also talking about individual patient decision making, and is there a split between these two? And what needs health technology assessment, what does not? For example, if you're talking about diagnostic, it needs to go through the regulatory channels, but maybe policy model may not need that. So where do we create that distinction? I don't know about that, so maybe that's a question I would...
Good, very good, important question. Which level of decision making that we are addressing? David, please.
Yeah, it is a great question. I think the interventions and the difference between the patient level and the more macro policy level can be put into the modeling relatively easily. We have our patient pathways in terms of our decision trees, economic models, and there we can envision, really simulating based on good local data what different choices mean at that level. And similarly, at the broader, more macro transmission level, we can incorporate vaccination or policy goals and evaluate those impacts and have them in the same sort of simulation framework. How that then transfers up to HTA goes well beyond my expertise, also not being involved in HTA, but in the research. And indeed, that's something we're interested in hearing more about and discussing.
Please, Mike, Jean-Michel. Yeah.
So Jean-Michel from GARD-P, not GAPI. So I think HTA, so I'm currently working here in Thailand on procurement for antibiotic. And I think HTA is, of course, essential in the discussion with the policymakers, but not only. I think also with pharmaceutical companies. There is now within the generic manufacturers globally, outside of Europe, outside of the US, those are really savvy businessmen and businesswomen who know their job, who know their business, and they want to make money. They are private sector. And I think HTA, some element of HTAs are really important in the conversation when you want to start engaging with producers. Yes, it's about volume, but not only. And so that I think that's quite interesting. One worry I have in some of the things you mentioned is the gold standard. So gold standard are very good, but they might also prevent innovation. They might also make things expensive. So I think gold standard are very good as a reference, but it's also, so I'm also a very big advocate of South-South collaboration, and I think it's also important that we let countries or region decide by themselves, based on gold standard, that's very good, how they want to proceed.
Good. Mike, do you and there's something about gold standard? Yep.
Yeah, no, I completely agree. And so, bronze standard might be a better sort of term for. So, when we look at the WHO recommendations in the Aware Book are formal WHO recommendations. So they are formal WHO recommendations, and but dose and duration are not. They're guidance. So there's a slight difference between those as well. And the evidence base for that was after a sort of kind of a major piece of work reviewing over 1,000 clinical trials to try and sort of work through, the sort of options for treating that. But clearly, as you know, for many of those, the levels of data that's coming in to influence those decision making and that guidance is very limited for areas like hospital-acquired pneumonia or other ones. Then, as days go working through all the clinical infections, some of them are relatively robust and some of them are sort of much less robust. And the new reserve antibiotics are a good example of that, where there's sort of kind of emerging evidence, and that will change over time, over sort of as more and more sort of clinical trial data emerges. So I think the key of this is, and just to go back to your last question, we're absolutely, and indeed as Aislinn was discussing, what we've been trying to do is we've actually took a benchmarking approach for sort of optimal use to say that actually this is all about peer-to-peer. And in the end, if you can match countries on their resistance data, on their burden data, on their population demographic data, and start to have a look and say, well, you're very similar within your region, PAHO, for example, or elsewhere, but actually, and all you're doing is these are national decisions and national discussions. But I think data to help allow countries to reflect on their own use of antibiotics and how that varies from other countries is may be helpful.
I understand that GAPI is trying to make also the data is publicly available. So the gold standard built on that public available data. So it's subject for challenging in the future. So I hope this is not going to be a barrier for innovation, as you mentioned. But I think John put
good point.
Yeah, put one interesting context that normally HTA is not just, a way to get input and make a decision without giving the output back to the industry. So I think that is very important that we never really think through how we can make the GAPI useful also for industry partners. But having said that, maybe I asked, maybe Alex Cook, I try to give him a hint. So because Alex present interesting regional initiative, not regional now, it's global, on advanced ID. They are developing or testing new antibiotics. And we know that the problem is that once the new antibiotic available, people in this region, especially low middle income country, we need to wait maybe 3, 4, 5, or even 6, or if in worst case, maybe 10 years to be able to access to the public program. So now with the advanced IDs supporting the development of new antibiotics, are there any suggestion, or can you see any link that maybe make GAPI, make advanced ID and GAPI to be able to synergic and work together to ensure that advanced or new antibiotic can be accessed to the public program at much quicker pace?
Okay, so I should stress that I don't work for Advanced ID. I'm only trying to sell them to everyone. I think that they would be very interested because clearly this is something the leadership is very passionate about. And because it is a regional initiative, first and foremost, we want to make sure that we can benefit the region. I'd like to turn back the question to you. What are the barriers that it takes 10 years before it can get licensed? Is it because the manufacturers are prioritizing other markets first, and they only later on send information through to get approvals in Thailand, etc.? Or are there other barriers which are getting in the way? Because it's going to be those determining what those barriers are that tells us how we need to overcome the problem.
I think it's many things, not only a single answer, but I would say maybe first is that it's about the awareness and the experience of using that antibiotic, which is I think can be overcome once it get into the market. But the second one I think is more challenging for HTA agency is that to get a very reliable data to predict about what to be the likely cost and likely to be the impact, budget impact, and the impact, health impact that justifies public investment. So I think this is not going to be easy and it's very one by one. So that the thing that I think that it will help if GAPI is making the model, that the model is also adaptable to the new context of new antibiotics. And that is the countries that going to address that question can adapt in order to answer local policy questions.
Okay, so 2 responses to that. So the first is, please allow me to introduce you to your colleague in the School of Public Health in the US who's involved with this, and then you can have the conversation about that. I think they would love to find out more, and for you also to find out about them. The other point I would just like to say is that, so although I mentioned that they're in the process of doing a phase 2 clinical trial for a novel antibiotic, apparently there were over 20 submissions as candidates for that trial. We were only able to fund one of them from the existing funding stream. There's a lot of development of possible antibiotics.
For example, I can see one thing that if that trial data can be available to GARP team, I think that help a lot in terms of making model parameter fitting to the new context, etc. We don't need to wait until the country use data and collect the data locally. I think that it will take maybe another 5 years, 6 years.
Let's have the conversation. I'm very optimistic.
Okay, good. Thank you, sir.
Can I comment on this? So traditionally, health systems are not proactive. They are reactive. They are waiting for the drugs to arrive in the country. And that's one of the issue in terms of access. At the beginning, the drug is very expensive, so there is no market, and the drugs are usually procured through different mechanisms that exist in most countries. Where HTA is very interesting is when you start discussing, okay, which other treatment option do you apply if you don't have access to this drug? What would happen if instead of using this drug, you would replace with this newly available drug, which is yet expensive? Then you can calculate that. And then you realize it might be affordable. So you go back to the industry, but it means you have to be proactive, which health systems are not used to. You go back to a potential manufacturer and say, actually, if you lower your price, this is the market. So this is where HTA is really, really useful in terms of access.
Price setting may be also one of the benefits. If GARP can synergistically working with, industry that they are developing technologies. So they may be able to advise industry in advance what is going to be appropriate price to make that new antibiotic represent value for money in different settings, etc. Mike, please.
And I think that's absolutely right. So I agree entirely with what you're saying. It's slightly more than that. So what Aislinn was discussing earlier on was that that in fact you can also work out what the market should be. Because using data, and we've been working very closely with Graham, obviously, and Ben Cooper and the teams there to actually try and GARP produced with Jen some very nice models of sort of estimates, but then using another sort of we've now taken that and then have estimates for sort of antibiotic use at a country level, so that actually it's trying to. And then I think taking those into the model, it's working out what the impact of that would be, and then what what you would need in terms of access, I think, to then try and treat all that, and then that in fact in some ways actually also helps to design what that antibiotic could cover and should cover as well. So I think we're now in a place where using all those combinations, I think it puts in a much more robust place. And we've chatted to Monica and Seamus around talking much bus pace about sort of kind of predictions in the future for other new mycin and other new components around that. Yeah, thanks.
Can I ask, will the modeling be looking at subscription models for the new antibiotics? Because I guess because one of the major issues for manufacturers is that they don't want to develop a new drug if then subsequently no one wants to use it because you want to keep it back as an emergency last line of defense So I know that subscription models have been spoken about as one possible approach. Are you factoring that into the modeling structure, or what?
David, can you respond? Maybe give them some
so the short
justification to the audience to why.
The short answer is no. We're not looking at subscription models. It's something we talk about, something we're aware of, interested in. But ultimately, we're more focused in a first instance on interventions that have proven efficacy and impact, trial-based evidence to parameterize the models. A potential future extension, absolutely, GAPI 2, 3, 4, something like that, but it won't be a top priority.
So for the audience who not very familiar with subscription model, is the Netflix model. I mean, you pay once and it's not matter how many you're going to use that antibiotic. You pay at a fixed price. Yep. Please. Yep.
But I mean, just to extend that, the concept is the framework should inform the model. So if you take the York assessment, or you can think through the assessments that have been done with the framework, as was taken forward for the analysis of the new antibiotics in the UK, sort of in the NHS and the sort of in the HTA approaches taken towards that. So I think what we're trying to do is develop a sort of a more broader framework that is, in fact, that will allow that and other diagnostics and other interventions. So I think the subscription model is potentially something that is obviously but in fact it needs to have a broader remit than just the new antibiotics, if you like, and therefore try and provide the comparative efficacy across a range of other innovations as well.
Please, Dr. Rulak.
I'm not sure my point is useful, but I think I should say it. So I'm from Oxford University and also work for the, used to work in Thailand. So I think one thing that you're talking about your model, and I really agree that you mentioned about the health system, and you also mentioned about the health system. And you said that you want to use this model, which is an example of Thai data and the UK data, but then modify it for other country. One thing that I think you should think about that is the health system for another country to make sure that the model is able to modify, because basically the UK and Thailand have the USC system. So it's kind of more like similar system, but other country, they totally different. Japan, India, and then other country. So if you think about that at this point, maybe help for you to easy to modify. But that's my thought. Thank you.
Yeah, it's an excellent point, and thank you for making it. Definitely something we agree with, are aware of. Part of GAPI in a first instance is working closely with HITAP. That involves capacity building and making sure that the complicated modeling structures coming out of this can be used and adapted by local teams accessing local data and building it up for themselves. And so any future extensions to other countries would need exactly that, and not just thinking about data ownership and access, but also, how does the model structure fundamentally have to change because you don't have the same reimbursement structure or people access healthcare in a different way. Yeah, and so that's why really any country adaptation requires that close collaboration and buy-in from partners to help build it for themselves.
Yep. So for those who are not familiar with HTA Link, is a network of HTA agencies. It must be public funded HTA agencies. So most of them work for the government. Now we have around 50 agencies around 20 settings and countries in Asia Pacific, from South Asia, Southeast Asia, East Asia, and Australia. So that is the agency. If you work in that regions and you are not from the agency, you found that this GAPI project is relevant to your work and you want your HTA agencies to work with us. So I think we are very grateful. Even through HTA Sharing Network, which we have annual meetings, or through the HTA Secretariat. So you go to Google to HTA Share Link and then you email to the Secretariat, which is HITAP. Yeah.
Okay, so thank you. Since we are close to the time, I would like to thank you for the meaningful discussions as well. Since we're close to the time, I would like to briefly summarize our discussions. So basically, for the on the reflection, it would be the cost effectiveness models would be like very meaningful if it's like would be adapt to the specific context of the countries, and also it would help in addressing like the equity problems in accessing new antibiotics, and also that we also need to be looking at the industry perspective as well, which is also highlighted in the discussions, and on how HTA would help improve the access of new antibiotic appropriately. And lastly, is very important thing is that it's the value of working together across like not just like the not just UK, Thailand, but across like globally, that would help we tackle the AMR problems and also help prevent cures and preserve cures and prevent resistance in AMR globally. Thank you. And I would like to pass it over to Angela.
Thank you very much to our moderators, Dr. Yot and Ms. Titi Panchaya, as well as the participants for actively engaging during the Q&A session. So, we are now nearing the end of our side meeting, but before that, we are at a point, it's a time where you've all been waiting for. So for that, yes, Professor Mike, Dr. David, Dr. Sheila, and Dr. Yot, please come up to the front. So we are now going to officially launch the Global Antibiotic Policy Initiative, or GAPI. And for the participants, kindly stay in the room to celebrate this launch with us, as we will also have a group photo at the end. So in the video, there is going to be a countdown. So when I count, please do count with me and celebrate this launch together. All right, so lights, camera, action. 5, 4, 3, 2, 1, 0. Congratulations on the official launch of the Global Antibiotic Policy Initiative, or GAPI. Thank you for celebrating with us, and we invite all of you to join us in this journey to support GAPI moving forward. So congratulations to the GAPI team.